Welcome to all the people here who have come to listen to Stephen talk this evening. This event is part of a series of stakeholder engagement activities that we have designed to stimulate dialogue on important issues related specifically to optimal aging. And this is being achieved through public talks, citizen panels, and debates. And all of these are conducted in the context of McMaster University. Can you hear me okay back there? Okay. And in general, just to give you a bit of the context, that McMaster has had a strong commitment to the study of optimal aging. And in more recent months or recent years, it has become a high priority for the university as a whole. And in 2012, the university received a very generous gift from Ms. Suzanne Labarge. And this was a gift of $10 million. And that started the McMaster University to support research in optimal aging with the theme of mitigating risk, maximizing resilience. And the aim of the Labarge Optimal Aging Initiative is to keep older adults healthy and active for as long as possible. And the initial focus has been in two major areas. We have this particular initiative has funded many of the research projects on campus with different researchers from driving and older adults, looking at genetics and nutrition and many other projects. But one of the major flagship projects of this initiative is a optimal aging portal, which is going to be launched sometime in the spring. And the idea behind this aging portal is to provide clinicians, policymakers, and citizens like yourself the evidence-based information that allows people to make decisions about how they want to live their life and how it promotes healthy aging or optimal aging. And what we want to do is to become the voice for and those committed to optimal aging by capturing and conveying the voices of public, seniors, and caregivers through citizen engagement activities such as tonight's event. And in addition to this event is also organized by McMaster Health Forum with the funding again provided by Suzanne Labarge Optimal Aging Initiative. And the agenda for this evening is that I will give a quick introduction of some of the things that are happening at McMaster in general, some of the major highlights. I will set the stage for this evening's presentation, and then Stephen will come and share with us his thoughts about the topic at hand for tonight. And at the end of the session, we will have a question-answer session where we hope that you will ask some questions to Stephen or myself, or we can work together to be answering some of the questions. And it might turn out that we might also pose questions back to you in relation to aging brain and the neuroculture and so on and so forth. So with that, I will sort of begin my initial few slides. Just to give you an idea that at McMaster, we are talking about creating a knowledge hub for optimal aging. And one of the areas that we are trying to bring different things together is McMaster, creating a McMaster gateway to optimal aging. There are lots happening here. These are some of the major initiatives that are going on at McMaster. As I mentioned, Labarge Optimal Aging Initiative, where there are certain research projects that are being supported, as well as the optimal aging. We have a Health Canada project, large initiative looking at helping people stay healthy at home and sort of linking it to the primary care. Gilbert Center on Aging, Amanda is somewhere here in the crowd, which is looking at and focusing on the social aspects of aging and its link to health. We have economic program that looks at economics of aging and social and economic dimensions of aging research program, which is called CDAP. And another major initiative is Canadian Longitudinal Study on Aging. I know some of the people who are in the audience here are part of that initiative, and really we appreciate their contribution to that initiative. I am the lead. And I'll talk about that and the Optimal Aging Initiative a little bit more. Canadian Longitudinal Study on Aging is a study of 50,000 people between the ages of 45 and 85. And we are going to be following these people for the next 20 years. And we are trying to understand why some people age in a healthy way and others don't. And the idea is to look at the whole aging process from cellular biological function to social aspects. And it sort of covers huge amounts of, it looks at diseases, it looks at physical function, it looks at psychological function. So it is a very comprehensive program, and right now we are at the beginning stages of that project, and we have recruited almost 35,000 people, and we have 15,000 more people to go, and then we keep going back to people again and again. And the other initiative is the, as I mentioned, the Optimal Aging Portal. And the idea behind this initiative, which is again funded through Suzanne Labarge's generous gift to McMaster University. And I have some of my colleagues who are part of that portal development. Brian Haynes, Brian, want to raise your hand, is here. And I don't know if Anthony's here or John and Maureen Dobbins. And the idea behind this initiative is to sort of consolidate majority of the evidence that exists from scientific literature, look at the quality of the evidence, synthesize in a way that it can be targeted towards clinicians if they want to use that information, or the public policy or public health personnel, or the citizen. And there are many features within this Optimal Aging Portal. You can have access to actually publications which have been appraised for quality, or you can look at the summary of the information, or we are going to have blogs that actually sort of bring some of the experts, look at the science and the evidence, and contextualize and give you information to understand a particular area. For example, if many of you probably watch Dr. Oz show. How many watch Dr. Oz show? Quite a few, right? And he is notorious for giving out advice which is not based on science. So one of the things that he has been talking around is that how coconut oil is good for your brain health. The question is, what is the evidence in relation to that? And the Optimal Aging Portal will look at the evidence that exists in scientific domain and give you information so you can make some informed decision. And the idea behind that, the launch of that website is going to be sometime in April, right, Elena? That's the target date. And hopefully many of you will go to that website, and we will also have some sort of a mechanism of feedback, whether you like what we are producing and what else you would like to see. So what I'm going to do now is to set a little bit of the stage for what Stephen is going to be talking. And many of the people in the room know the issue of aging and what we are here in the media and the news, in the newspapers, or politicians even are talking more and more about it. And some of the demographers and some of the thinkers in this area also say that population aging is unquestionably the most important demographic force of the first half of the 21st century. And part of this statement comes in a way that it sort of, at the first instance, if you look at this statement, it seems like this is going to be a huge, it is going to have a huge impact on the governments, on the society, or individuals. But if to understand what impact the aging of the population has on a community or a country or a state, you actually have to look at the nuances of aging. It is not that black and white that having more people is detrimental to the cost associated with the healthcare system. And there has been a fair bit of literature or some of the publications in the newspaper and media that sort of portray as an apocalyptic phenomena. But in fact, if you look at the science and the data and the evidence, it is not at all like that. But there are some realities in relation to how the population is increasing worldwide. This is not just a Canadian phenomena. You can see by the time projections indicate 2050, there's going to be 8 to 9 billion people around the world. And if you look at further data, that the fastest growing population within this 8 to 9 billion people are the people over the age of 65. And within that, if you look at some of the number, in 2010, we have 530 million people around the world over the age of 65, and this number is going to be 1.3 billion by 2040. And within that, one of the fastest aging segment of the population is 80 plus. And as policymakers, politicians, healthcare providers are sort of working to see how well we can provide care to these individuals and what kind of social support systems or community support systems that we will have to create. And one of the things to keep in mind that 80 to 85% of the people like yourself who are functioning very well, and we have to sort of come up with strategies to promote healthy lifestyles and promote healthy aging. But there are 15 to 20% people who have very complex needs in relation to health. And we also have to think about how do we provide best care to those individuals in a most economical and efficient way. And within that, one of the things that aging population is doing, because we know the life expectancies for women are a lot more, and around the world, there is also a gender inequality that is happening in relation to this aging of the population. There are going to be more women around the world, and women also have a higher health or chronic disease issues. And traditionally, there has been income inequality in this population as well. So how these factors are actually going to play out in relation to the aging of the population and the social and community services that we will have to provide. And we always think of aging of the population as a developed world phenomena. In fact, it is actually happening around the world. Proportion-wise, they might not be that big, but countries like India and China have huge populations. So the absolute number of people who are going to be aging is actually increasing quite rapidly. And this particular graph shows that if you looked at the top line, which is the developed world, and you can see the steepness of the curve for the developing world and how these numbers are actually increasing. If you look at some of the statistics, for example, France, when it went from a life expectancy of 47 to 73, it took France almost 113 years. And China has gone through that increase in life expectancy in less than 26 years. And it is a very rapid aging of the population. And many of these countries have to think about providing services that meet the needs of the older people, especially living in the community. And in China specifically, with a one-child policy, their social issues are becoming even more complex. And within that, which is the topic at hand today, we also hear a lot with the aging of population that we are going to have a huge burden in relation to dementias and the memory impairment and Alzheimer's disease. And it is true that these disease incidence or prevalence increases with age, and what implication that has and how we sort of see a person with a memory impairment and dementia becomes an important, because it's not only a medical issue, but it also is a cultural and a social issue, and how we sort of examine that is a important issue. And you can see this phenomena of prevalence of dementia increasing around the world. It's not only, again, a developed world issue. Here you can see the bottom curve shows here the increase in numbers of people with dementia, and that is the high-income countries, and the top part is the low and middle-income countries. So it's, again, as the number of older people increase, especially the 80 plus, the prevalence of these conditions is also going up. And these are some of the numbers related to global distribution of incident dementia. And you can see North America represents around 11%, Europe is 30%, Asia altogether is going to be somewhere 40%. So it is an important issue, but you will see in the media or even the Alzheimer's Society of Canada or America will use statements like 1 new case every 4 seconds of dementia. And if you sort of start to ask people around the country what is biggest fear in relation to aging, many times people talk about memory impairment and loss of memory. And the question is, how much of it is a fear created by what gets put out in the media, and what is the reality in relation to how people live with dementia? And I've learned a lot, not as a researcher who works in this area, but also providing care to my father who has dementia. And there's more to brain of a person. There's a lot of other parts of the body that are as important, and some of those things that we are going to hear from Stephen later on. And sort of seeing my father as a person rather as a functioning or not functioning brain actually has opened my eyes as a researcher and as a son, how I sort of deal with issues related to dementia in his case. So just to give a quick overview of some of you who might not know what dementia is, because it is important to understand the different stages of dementia and what types of different dementias are, and what Stephen might talk in the later stages of his presentation. It is an acquired disorder. It's a diffuse cognitive deficits. Usually it affects memory, and it has other symptoms such as executive dysfunction, aphasia, and other symptoms. Deficits sufficient to interfere with daily function, and there is no magical diagnosis of this condition. It is basically the clinical history that you take, and it doesn't just happen if people have a delirium or depression. It's more generalized than that. There are different types of dementia: Alzheimer's, mixed. You will hear these things if you ever go and talk to your doctor: Lewy body, frontotemporal, or vascular. But 80% of all dementias are Alzheimer's or mixed dementias. And here it is the interactions between different types of dementia. You would say vascular dementia and Alzheimer's dementia are the two major types of dementia that clinicians see in their patients, and many of them have mixed. So 80% of all dementia either are combination of vascular Alzheimer's dementia or vascular dementia or Alzheimer's disease itself. And the symptomatic domains of Alzheimer's disease over time are this. When you first start to see, you see changes in mood. There is a change in cognitive function. There is a dependency in relation to function that you have to provide help to the individuals. You see an increase in behavioral problems, and then those things decline, and then the actual function or the motor function starts to go down. The reason I'm presenting this slide is that as a caregiver or a person who's dealing with someone with dementia, you actually go through very different emotions and perception of the person you're providing care. And many ways, when you are sort of struggling with some of these things as a caregiver, in my case, as a son who's knowledgeable about this area quite a bit, you actually see the person differently, even though my father, in my case, hasn't changed, other than that his memory has started to fade, his moods change, and he was moody when he was younger, and I never sort of paid attention to that, but now I pay a lot more attention because there is a particular diagnosis given to his condition. So when we are thinking about a person with Alzheimer's disease or dementias, we also have to think about who they are as a person and where these things fit within the personhood of that individual. So I was going to talk a little bit more about it, but I'm not going to take time away from Stephen. There has been a lot of focus in medicine and in research in developing treatments or medications for treating dementia. And the success actually has been very poor. Many of the drugs that have come haven't been that good to either delay the symptoms of the dementia or actually treat dementia. So there's a lot of research, a lot of money, a lot of investment that is happening. So one area is that we should sort of take a lot of resources and put into that area, or we also think about alternate way of providing care and think about what we are doing right now might be flawed. And hopefully that's something we will be hearing from Stephen today, that how should we see the memory impairment and dementias in general from a cultural point of view. So those were some of my initial thoughts. With that, I'd like to introduce our speaker tonight. And Stephen Katz is a professor of sociology at Trent University. He's author of Disciplining Old Age and Cultural Aging, Life Course, Lifestyle, and Senior Worlds, along with numerous book chapters and articles on the sociology of aging. His current research is on the cultural aspects of memory and will be part of a new book on age, mind, and self in later life. In 2009, he received the prestigious Trent University Distinguished Research Award for his work in critical aging studies. So please join me in welcoming Stephen.
Thank you. And so this is just the next one. Thank you, Parminder, and thanks to Parminder and Julia for inviting me to speak with you today just about some general reflections about neuroculture memory and the aging brain. At the outset, I want to say I'm a sociologist. I'm not trained in medicine or psychology or the professions, so my comments are as a sociologist, as an outsider, looking in a way. So I'm very interested not only, as I'll talk about, in the sciences of the brain and aging, but the culture of the brain and aging. At the top, I have a banner of a recent project I'm part of, funded by CIHR, called Perceptions and Realities of Mild Cognitive Impairment Diagnosis and Treatment for Older Adults. It's a project I'm working on with another sociologist and psychologist at Trent University that's looking at mild cognitive impairment culturally, medically, and above all qualitatively, to understand what people themselves see through focus groups and interviews about their own perceptions of memory and memory issues. What I want to do today is just have some general reflections about the history of memory and aging, how the two came together, some questions about current popular culture, and especially exercises and regimes and health to do with the brain, and above all, ask the question of why is the focus on the brain today of such paramount importance in terms of asking some of the bigger questions about humanity itself. Why today is the brain the object of inquiry, anxiety, and certainly introspection in terms of what it means to be human, what it means to be successful, what it means to age successfully. Why has the brain become so important for those kinds of questions today? So I'm going to be looking at that in kind of conclusion, and as Parminder said, I'd be very interested, of course, to hear some questions from you, pose some questions to you, and make this an interactive experience. To begin with, by neuroculture, we have to talk about not just the science of the brain, but how the sciences of the brain, in a way, have overspilled the laboratories and the clinics and the experimental zones in which they're occurring. We all have a sense, curiously enough, in our society today to do with cognitive fitness. In fact, as I'll talk about, we have metaphors like cognitive fitness, brain health, memory health, which none of us really knows the meaning of. They don't really have consistent meaning, and yet we seem very, very concerned about them. We seem very anxious in a way about our cognitive fitness, even if we don't exactly know what that means. Gerontologists give us some new terms like cognitive reserve, cognitive plasticity, etc. We don't really know what those things mean either, but they sound good, you know. To have a plastic brain is actually a nice thing to have, we think. It's expansive, it's intervenable, it's changeable, we can work on it. It presents the brain as something that's an open channel to optimization and improvement in health in general. So what's interesting then, cognitively, I have a picture of a boat here. Oh, okay. Is some of the ways in which neuroculture has spread into industry, has spread into new hybridized forms of academic inquiry. We have neuroeconomics, we have neuromarketing. The military has made great use of neuro research. We have nutraceuticals that are food for your brain that you can eat to do whatever they're supposed to do for your brain. We have neuro exercises, as we'll talk about later. There are brain gyms now, which originally developed for children, are now in states like California inviting older people to join. And you get a membership in a brain gym, just like a physical gym. You have exercises, you have a trainer, you go through various forms of measurement that you're improving. You carry a card around, I guess, with you saying, I belong to a brain gym. So all these kinds of things. Added to that are the advice industry, full of books. Some of the examples I have here: Beef Up Your Brain, the big book of 301 brain-building exercises, puzzles, and games. Sex, Aging, and Memory was part of a conference. I find what's interesting there is how sex, aging, and memory combined in that conference in terms of a general will to health. You can't just want to be healthy physically anymore, or even sexually, but also cognitively. And more we see in health magazines and all kinds of fitness magazines, cognitive dimensions added to self-improvement regimes of your own. So it's not enough to work on your body anymore. You are now encouraged to also work on your mind and your brain for reasons that Parminder pointed out, and I'll talk about also in a moment, which is the great fear of memory loss itself as a kind of indicator of dependency and aging. Keep Your Brain Alive, I think, is a crazy kind of title, because your brain is alive. I don't think you need a book to help you with that necessarily. At the bottom is also a bunch of drinks with the word neuro in them. There's Neurogasm. Won't have to explain that too much. There's Neurosonic to help with your hearing. There's Neurosleep. There's Neurosun. There's Neurobliss, Neurosport, and Neurotrim. Apparently part of our brains are now also responsible for diet problems. So they're working on the neuro to deal with your diet as well. So I find it kind of interesting then that the very concept of fitness has moved beyond the body and moved outside of physicality to now include the space of the cognitive itself, even though the language of that cognitive is littered with metaphors and language and even myths that we don't quite grasp, that we may not understand. So it's a curious culture that we have a will to cognitive fitness, even though we may not know what that means. We're interested in cognitive enhancement, but we may not know what enhancement actually means, or whether we should even be enhancing our minds or not, what that actually entails. And as Parminder says, there's hundreds of drug tests going on for all kinds of memory testing and memory boosting, etc. The other part of cognitive culture certainly involves popular science, but also the politics of fitness. We have an aging population. It's creating and stirring up images with terrible metaphors like the gray tsunami and all kinds of similar apocalyptic sorts of images that the aging population is some kind of economy-eating monster that will take over what's left of the welfare states, leaving younger generations with less and less, working harder and harder to support them with lower dependency ratios, with the result that we have a greedy geezer, as they've been called, boomer population, who will be the beneficiaries, the last generation who will be the beneficiaries of our prosperity. And after that, le deluge. So it's interesting how that kind of imagery is now coming into cognitive discourse and neuroculture as well. In other words, the plastic brain, the open brain, the workable and intervenable brain also has political implications for this aging population to encourage and indeed coerce us in some ways to work on ourselves, to be the center of our own intentions. Because if you don't take that kind of individualistic responsibility, then the image is you in turn are responsible somehow for increasing health costs. By not working on yourself, you in turn are responsible for the demise that's about to hit certainly Western industrial and welfare states. An incredibly unfair sort of equation. That lack of responsibility is equivalent to a kind of gerontological demise of our future populations. The brain has now entered that too. So knowing about your brain has now become part of that neoliberal personalized responsibility for self. For example, Time magazine put out a wonderful guide called Your Brain, a User's Guide. So you will know how your brain works, you'll know what to do with your brain, what to eat, what part functions, and as more and more of those parts function in localized ways, as the second slide shows, the more you're supposed to know about your own, let's say, cognitive self or neuro-self. The middle slide, again, is very mythical. These are all diagrams. They're artistically rendered. We'll talk about brain scanning in a moment. Shows the spot for addiction, for example, the spot for dependence, things you should know so you won't be addicted, you won't be dependent. So the knowledge, the mapping of your neuro-self has become part of the project in a way to self-care. The third slide, mental capital and well-being. I think that's a wonderful title. It's a text from Britain. Mental capital. Just think about what that would mean in terms of performance, dependability, in terms of a population that can work, that's functional. Again, it's coming down to including the cognitive in the equation of performativity itself, and being a responsible and productive citizen now includes what's between your ears. The idea of mental capital being added to economic capital, cultural capital, the other kinds of capital is kind of fascinating in itself, because how would that ever be measured, really? And how would any of this ever be measured is sometimes inconsequential to the political and social emphasis that's being put on the rigors of the neuro-self to be responsible. And above all, to somehow try and prevent memory loss. And memory, as we'll talk about, is the key dimension to cognitive fitness because of its implications for the aging population. Part of cognitive culture is our incredible ability to visualize the brain. I mean, colored slides only came into existence about 100 years ago. And since that time, we've had this incredible leap forward to technologies that can scan the brain and visualize them. And what's interesting about the visualized brain is sometimes we don't know what we're looking at, but again, they symbolize a real significant aspect of what it means to be human. Obviously, as we'll talk about later, we don't even know if you have Alzheimer's disease really until you die and there's an autopsy on your brain. And we don't want to do that to you while you're alive, so we have to wait till you're dead. But by then you're dead, so maybe who cares in some ways whether you had it or not. It's an interesting irony. So being able to visualize the brain is part of the ability to conceive of ourselves, our humanity, in neuro sorts of ways. It also gives us a kind of compassion on the one hand for the person with brain problems, and on the other hand, a kind of identification, an identification mechanism to link types of persons with types of brains, which is a new kind of foundation of humanity itself. If you look on the slide on the left, it's interesting they divide the brain itself into advanced Alzheimer and healthy brain. So if you look at that kind of slide, you get an immediate sense of the space between not just the healthy brain and the advanced Alzheimer's brain, but the healthy person and the person with advanced Alzheimer's. In fact, we start to grow some compassion for that brain. We start to feel sorry for that brain in a way. You know, you look at those deep valleys, those dark areas, those shrunken parts, and you feel sorry for the person who has that brain. And on the other hand, we relieve that person of some responsibility because, after all, there is a disease. It's in their brain, right? The other slide shows brain scans, colored brain scans of normal, mild cognitive impairment, and Alzheimer's disease. Again, if I didn't show you those labels, but just those three brains, you probably wouldn't know what they were. But by adding the labels, we add a dimension of identification that once again gives the brain a kind of humanity, gives it a kind of element of personhood. Those of you who do brain scanning or know about it probably know that the static brain scan is really the result of hundreds and hundreds of slides. It's not just one. And this is a kind of combination of perspectives and views, like an MRI that takes lots and lots of angles, and then you end up with an image, right? The other thing about the coloration is that has a lot to do with the researcher or the clinician's own choice of colors. You can choose colors, almost like wallpaper a little bit. Not that you would want this as wallpaper necessarily. Could be interesting in your bathroom maybe, but the idea that you could make a depressed brain blue or black, for example, is a kind of fascinating part of brain scans itself. I'm not saying researchers manipulate it, but on the other hand, they do have to present differences. They have to show variance. So when we look at these brains, we have to ask ourselves, not just what are we seeing in terms of brain or cerebral structure, but what are we seeing in terms of people? What are we seeing in terms of types of persons when we look at brains? And what has brain scanning done to recategorize not only our empathies and our sympathies, but these types of persons? Does a good brain mean we have a good person? Not necessarily. We could have brains that have an incredible mess inside them, and the person is still a good person. We could have unhealthy brains and healthy people. Some of you know the famous nun study that was done, in 1988, I think, was a study of nuns who, it turned out, did have all the physical and cerebral symptoms of Alzheimer's disease, but were asymptomatic. They did not express behaviorally the symptoms of Alzheimer's disease. So isn't it interesting that we could have Alzheimer's brains and not demented people, too? In fact, we all, in some ways, have sort of Alzheimer's. We all have things going on in our brains, the plaques and tangles, as we age, and our aging brains are moving on. But that doesn't mean that we have a consistent set of behavioral types of person that result from it. Yet brain scanning can give us the illusion that there is a tight equation, a lock, between a type of person and a type of brain. And I think we have to be very careful about that in neuroculture because these images are so popular. Stephen Rose also, who's a neuroscientist, says that despite decades of theoretical and experimental work, we don't know how memories are made. And I think this is interesting coming from a neuroscientist. He says we don't know how and in what form they are stored in the brain or the processes by which they are retrieved. We are unsure whether memory capacity is finite or bounded, whether we forget or simply cannot access old memories. And I think this is a very profound statement, a very positive statement in some ways. As a leading neuroscientist who's spent most of his life studying brains and memory, and this is one of his conclusions, that we absolutely may not know everything despite all the work that we've done. Not only is there much more to learn, but we may have been making some big mistakes along the way as well. I want to talk to you a little bit then about the history, some historical glimpses, some shots in a way at our historical record whereby the body and brain and memory and aging came together. In a way, I'm interested in sort of cognitive maps, or maps of what it means to be a person. It's hard to imagine, given the intimacy of our emotions, our feelings, our sense of self, that that intimacy could have a history in itself, that what it means to be a person, the package of things that we call personhood, like a Rubik's Cube, may have shifted and changed through time, so that our present, our now, is a result of a combination of different historical maps overlaid on top of each other. This is one of them. The first philosophical treatment of memory and the brain and aging has been credited actually to Aristotle, so it goes back quite a ways. It was Aristotle who wrote a great book called On Memory and Reminding Oneself. I think that's a great title, On Memory and Reminding Oneself, right? That Aristotle claimed that memory can be worked on. And it was Aristotle that came up with techniques for helping us remember. One of them, which still remains today, these mnemonic techniques, is that we imagine a set of places in our brain and we deposit things in these places, and then we go to those places and retrieve them. We do a little neuro travel or mindful travel, and we pick up different things in order to remember them. In other words, we run through a set of mental places, he thought, to evoke a memory. And we still do this. When we say the terms, in the first place I think this, and in the second place I think that, and in the third place I think this, that goes back to Aristotle, that we have places that we delineate, that we run down. So this kind of idea goes back quite a ways. But Aristotle asked some big questions that we're still asking. He asked, how do memories come into our minds in the first place? We're still asking that question. He asked, how is it that memory is both physical, emotional, and spiritual? How do memories get stored? His metaphor for memory storage was the wax tablet, that you can impress things in wax, and eventually they would get duller and harder, or even erasable, and other memories would be impressed over those wax memories. So that was his metaphor. Big distance from our metaphor of the computer, certainly. Aristotle was very influential in medieval thought. And medieval thought included something called the ars memoria, which means the art of memory. Not the science of memory, but the art of memory. And I think the idea of memory being an art is kind of fascinating. And the main principle of the art of memory was good memory was dependent on how you remembered. Not how much you remembered, but how you remembered. What were the conditions by which you remembered something? For instance, the ars memoria warned against greedy memory, that you would try to remember too much, too fast, like we do today. We're always on edge, all our passwords and codes and computerized this and that. If only we could just download the whole computer into our brain, I'm sure we'd be very happy, right? That would go against the ars memoria, because that would be a kind of greedy memory, right? Remembering took time, it took patience. Sometimes it had to be the right time of day. Other times you had to eat the right foods. The ars memoria encouraged priests, for instance, to rub certain herbs into their head so that it would open their brains, like chamomile, so that they could receive memories. It also encouraged people to eat while they were reading. I think we do that still, most of us, right? Because it gets your senses going, it gets your juices going, because memory was a very physical thing. And it even encouraged monks, while they were training, to vocalize, to whisper and talk while they were reading to help them remember, right? So there are all these kinds of techniques in the art of memory to make sure you remembered well. It wasn't how much, it wasn't how often, it's how well, how artistically you trained your memory. And so books were wonderful kinds of technologies. People think in medieval times people didn't read or they were illiterate. Well, one of the problems with that is books were a very different technology than they are today. Books were an interactive space between mind and thought and word. They were ways in which you engaged in ethical forms of memory. So you would have the right kinds of memory at the right kinds of time. And I like that idea that we have memory as being a kind of art, as something that gives us joy, the medievalists wrote about, something that gives us happiness to remember things in certain ways, if we do it well, if we remember correctly. On the left is an example, by the way, of one of those places where different memories would be deposited. So this was a kind of theater. And you would run through the theater, go behind a door, or go into a corner and retrieve your memories. On the right is an example of using the hand to remember things. And hands have always been a very important device for remembering. And we still do this when we're talking, right? In the first place, the second place, we're always using our fingers and hands to demonstrate memory. And especially to remember prayers, parables, religious kinds of evocation, hands became really significant. So memory was very embodied. Food, what you drank, the time of day, what you ate, your hands, how you remembered, what your mood was. It was a very physical kind of thing. That certainly changed historically. In the 17th century, we get the Enlightenment, which of course started to look at the mind as something that was rational, as the seat of rationality itself. And we get a couple of examples where the relation between aging, personhood, the brain and mind shifted. For example, John Locke, who some of you know, who wrote his famous essay concerning human understanding in 1690, had a treatise on what it means to be a person in relation to memory. And he said some things that I think are really lasting. For example, he had a section on retention and identity. And in that section, he makes it very clear that your coherent identity as a person throughout life rests on good memory. Sounds like a simple theorem, but think about that your identity throughout your life rests on good memory. And he says, and I quote, "Where memory is wanting, all the rest of our faculties are in a great measure useless." Useless. The prominence of memory really comes through here, and not just as mental or intellectual skill, but as key to your identity as a person. He says in cases of memory defects, including memory, he says, that moves too slowly, the result can be stupidity, and we don't want that. More importantly, Locke's concept of personhood is a continuity of time, where he says nothing but consciousness can unite remote existences into the same person. So you see the entire pre-Enlightenment concept of the body and its openness to the universe and the stars and its influence becomes very compacted in Enlightenment thought through the example of John Locke, who packs personhood into a rationalized image of memory continuity. And if you stop remembering, you stop in a way being a successful person, because you stop being rational. You stop being the seat, in fact, of the Enlightenment. As Ian Hacking puts it about Locke, the person is constituted not by a biography, but by a remembered biography. By a remembered biography. On the left, there's a slide by Robert Flood, wrote a fantastically interesting book called Microcosmi Historia that tried to show how memory in the brain was the intersection zone between macro universal forces and micro forces of the person. That it was the intersection zone where these energies passed each other. And he came up with some dynamic and I think truly artistically interesting images of the mind and the brain bubbling and popping and doing all kinds of things while it was being as intersected as such. But again, the brain becomes a seat not only of consciousness and of memory, but of constituting a rational personhood itself during the Enlightenment. And I think this has a building block, one of those layers of personhood I was mentioning at the beginning that underlies some of our concepts of dementia today. Because after all, we also think that a continuity of memory is a principal equivalent to a continuity of personhood. And that when memory is lost, our culture has given that person a denial, in a way, of their identity. And we treat people with Alzheimer's, and even with mild cognitive impairment sometimes, as losing their personhood. It's not just a brain disease again, it's a personhood problem, right? It's a decline in identity and agency, and certainly value. In the 18th and 19th century, we have a movement called the localization movement, where different writers and scientists, and even popularizers, thought that the brain could be the place in which personhood could be more identified through mapping, through finding functions of the brain, a very static kind of model compared to our connectivist, neural, networked, interactive models today. Started with linguistic theories like Broca and Wernicke in France, who tried to find language problems as a result of neurological damage. We also have craniometry during this time, which is a more popularized, but I think influential science or pseudoscience that tried to locate different kinds of human attributes in different parts of the brain. Craniometrists, you might know, also tried to measure the brain size to rank different statuses of persons. That's why women always ended up inferior to men, of course, because they thought men had bigger brains than women. I mean, Neanderthals had bigger brains than all of us, but, you know, we don't exactly think of them as so smart. So brain size is obviously not really linked to intelligence. They also felt for bumps around the head that they said symbolized certain criminal and aggressive personalities too, another ridiculous theory, of course. Still, the idea of localization was very powerful, was very popular, that in fact you could find human attributes, especially aspects of memory, in your brain, that you could produce a photographic plate and produce an image of personhood itself. Part science, part popular culture, part neuroculture, right? I mean, this is something that goes back to the 19th century as well. The picture on the right is an early 20th century picture based on language issues. And we even have Broca's area, of course, named after Paul Broca, and Wernicke's area named after Wernicke inside of our brain too. So we actually have the discoverers of brain science in our brain forever because they've given themselves these sorts of these names. The problem again is that we end up with this issue at the turn of the century, as Parminder was talking about, Alzheimer's disease. The slide on the left is Augusta Dieter, who is considered the first patient, the first Alzheimer's patient. And then Dr. Alois Alzheimer himself on the right, the German neuropathologist and psychiatrist who is credited with discovering Alzheimer's disease at the turn of the century. I think it's very, very interesting when we think about the culture of that time that this problem emerges. The culture at that time, when it came to aging, more or less believed that older people became senile and that senility was part of aging. Whether it was a disease or it wasn't a disease, you really couldn't do much about senility. That was just old Uncle Jack in the attic, you know, flushing his shoes down the toilet and having fun, and, you know, that's that. You know, he's senile, okay? What people like Alzheimer's started to question was, what about cases where we have symptoms of senility that appear in other points of life? What does that say about senility itself? What he was working on at the time, certainly with Auguste Dieter, who is not an older woman, was what happens when we have symptoms of senility occurring in people who are not old? What do we call that? What do we do about that? And this became something fascinating to him. This is the beginning, in a way, of dementia research. And he had hundreds and hundreds of other cases. And the amazing thing about Alzheimer's himself was he was never quite sure what he was looking at. He wasn't sure if he was looking at a disease. He was very ambivalent about calling it a disease. He didn't know if this was sort of senility. He called it early senilities. He tried to give it different kinds of names. Unfortunately, he himself died too young before getting older, or he might have used his own experience to think about his own research. It was left up to others to actually name it Alzheimer's disease and to solidify it into a disease. So here at the dawn of Alzheimer's research, we have the man who does the research himself not sure what he's looking at. He thought maybe we had a combination of symptoms, maybe we did not have a single disease, maybe we had various diseases at various ages. He wasn't sure. And yet from his work and onward, we have very much compacted a huge range of symptoms and disorders into a disease model. The amazing thing too about Alzheimer's is it took senility out of culture and eventually moved and migrated over all forms of senility. So we don't talk about people being senile anymore in a medical sense. In fact, gerontological organizations since Robert Butler in the 1970s very much discourage people to talk about older people as senile. You have diseases of old age, but old age is not a disease, was the message of the NIA and NIH in the United States. In other words, let's study diseases that come with old age, but let's not think of old age as a disease. And in a way, Alzheimer's made that break. We took senility, which was a disease, as if it was old age, and turned it into dementia and Alzheimer's, which is a disease of old age, but it isn't old age itself. That was the kind of questions, too, that Dr. Alzheimer was trying to come up with. And this was during a very ageist period in our history. Don't forget, industrialism promoted a kind of youth culture, an energy culture, a productive culture, full of metaphors of steam and technology and movement. Older people started to appear as slow, as inadequate, as unmodern, as old-fashioned. We have doctors such as George Beard in the United States writing pessimistic books like Responsibility in Old Age in 1874, where he claimed that maybe we couldn't trust older people in legal cases because maybe they didn't remember well enough to be witnesses, and produced a whole legal scandal over that. He wrote a book also called American Nervousness, which is a great title, in 1881. He also died in 1883 at the age of 44, the year before he claimed human creativity peaked. He claimed creativity peaked at 45. Unfortunately, he died at 44. So he never knew. He might have altered his view if he lived to 46, and passed that year and said, oops, I'm still creative. I better do some footnotes quick to American Nervousness. So we have Aristotle, the Ars Memoria, the lock-in Enlightenment identification of personhood with continuous memory, and the 19th century sciences of brain localization, all layering kinds of maps of what it means to be a human, to be aging, to be a creature of cognitive powers. And finally, the discovery and work on Alzheimer's disease, which put all those questions into a different kind of light as well. What happens when you outlive your mind? What happens when you have a body that functions differently relative to your brain? Well, we have this kind of problem, certainly today, as part of that lineage. Parminder mentioned the great crisis of Alzheimer's disease. The media, I think, has been, in a way, irresponsible for jumping on a bandwagon that presents Alzheimer's as the never-ending funeral, as the death of self, as the continual, this image of an imprisonment of self, as a slow killer. There's the Globe and Mail. Alzheimer's is the slowest killer, a disease that drains body, mind, and family. Can you think of anything worse? Dementia is our next national health crisis. Governments have no plans to fight it. The slide on the left, the worried, probably looks like a daughter of a mother. Alzheimer's isn't waiting, it's coming. It's coming for you. It's coming to all of us. It's a scourge, right? I'm sure all of you have seen hundreds of images like this, and I think we need to question them. What do they really mean? Why now do we have this image of Alzheimer's controlling our aging population, our future, just at a time when cognitive science itself has come up with more plastic, open, renewable, energizing kinds of models of the brain? So we have both kinds of things happening at once. We have this older sort of localization model of the brain disappearing in place as a static space, and a newer kind of networked connectivist model that at the same time is saying the brain is always changing, reforming neurons, is energetic, is fascinating, and has plasticity. Still, this image is winning out, and I think is a very fearful one. I teach a course on aging, mostly to younger people, and this is one of the biggest things they're afraid of. And they're in their 20s, and they're afraid of Alzheimer's. I mean, they may live another 70 years of worry. 70 years of worrying about their brains is quite a long time. That's worse than worrying about, your bodies, or whether that tattoo you got as a young woman is going to sink and sag, which it will. All of you have nice little perky butterflies. You are going to have battleships later. Okay? Just want to warn you as a side note, it will happen. So along with those worries, for younger people anyway, is this one. Then we have this interesting kind of phenomena, which is, well, if Alzheimer's is going to be such a problem, it's going to be such a scourge, if it's the death of the self, if it's the disease of our century, as it was been claimed. In the United States, they had the decade of the brain that worked on that under, believe it or not, George Bush's presidency. So we have this kind of crisis mentality that is receiving a lot of funding and a lot of attention around what do we do about the aging brain? What do we do about memory? Well, one of the things that came up in science was, well, maybe there are pre-dementia stages that we need to start looking at. Maybe there are things that are happening earlier that we're ignoring. Ronald Peterson gave the name of mild cognitive impairment to this kind of space, this kind of pre-dementia zone, mild cognitive impairment. There were other words for it that circulate, like benign cognitive impairment, benign memory loss. In other words, it's not quite a disease model, but it is a kind of disease nonetheless. Mild cognitive impairment is for people who do not exhibit all the diagnostic criteria for Alzheimer's disease. Mild cognitive impairment is also considered a predictor for some people to progress to advanced Alzheimer's, but not for all people. So that's a bit of a problem too. If you're diagnosed with mild cognitive impairment or MCI, will you get Alzheimer's disease? Well, the answer is yes and no. Evidence points to both. Yet what does mild cognitive impairment in some ways really mean, but a kind of, in a way, new worrisome state that on the one hand medically is significant because maybe we can do something here that will prevent something there. And so there's a lot of drugs being tested for MCI. There's a lot of interventionist strategies. There's new biomarker testing, some of you may have heard of, where they do lumbar punctures and look at amyloid scores. There's a lot of attention being paid to this because if Alzheimer's is a disease and the disease model says that while there is no cure, maybe there's a prevention, then we have to look for the space where prevention might be possible. And so mild cognitive impairment has become very important as that potentiality. But it is also very troubling because the criteria are inconsistent. The sciences are not, the scientists themselves do not agree on diagnostic criteria. Some don't even think it exists, don't even think mild cognitive impairment exists. We have either pre-dementia or no dementia. Others think that mild cognitive impairment is something that we all have or people will have their whole lives and maybe is just part of the aging brain and they normalize it. It's a mess. It's a mess, but it's a kind of, I think, fascinating mess Because after all, how abnormal do you have to be to exhibit memory loss? What are the statistical? And mild cognitive impairment moves normality closer to pathology. But it's in the name of prevention, which, as we know, is one of the great agendas of our time, right? So there are books, there are drugs, there's ways to deal, there's classes, there's workshops. It's a real problem, but the problem behind the problem is in many ways a fear of crossing the boundary between healthy aging and pathological aging, between what the British call the third age and the fourth age. Is MCI the beginning of your dependence? Is it the beginning of your decline? So you can imagine the ethical dilemmas of diagnosing someone with MCI. Imagine your questions. Well, does this mean I will get dementia? We don't know. Does this mean I should be concerned? Maybe. Does this mean I should do anything in my life, eat differently, exercise? Yes, of course, that all helps. But still, what are we really saying to someone when we diagnose them with MCI? I think it's a very anxiety-provoking, as you can imagine, if some of you have been diagnosed, possibly a very anxiety-provoking diagnostic, because it could or it could not lead to more. Yet, it's hopeful because you'll be included in studies, in trials, in new kinds of technologies of prevention. You'll be paid attention to in order to do something about it as well. And again, if Alzheimer's is a crisis and a disease, then we should be doing something about it. I want to just conclude with a few comments about forgetting, because we forget about forgetting when we talk about remembering. We've put so much emphasis on remembering that we forget. We all forget all the time. We forget a lot of things. And in fact, in a healthy way, that forgetting actually is necessary. There are people who can remember everything. Jill Price is one. She wrote a book called The Woman Who Can't Forget, a memoir, interesting subtitle. And she can't forget anything, and her life is miserable. She remembers everything, every bad date, everything, okay? We need to forget certain things to have a healthy narrative of ourselves. Friedrich Nietzsche wrote a fascinating article on the uses and disadvantages of history for life in 1874. This is his quote. He said, he who cannot sink down on the threshold of the moment and forget all the past, who cannot stand balanced like a goddess of victory without growing dizzy and afraid, will never know what happiness is. Worse, he will never do anything to make others happy. Forgetting is essential to action of any kind, just as not only light, but darkness too is essential for the life of everything organic. So maybe we need to stop criminalizing forgetting as a threat. Maybe we need to see a balance between remembering and forgetting as part of the ways in which we build biographical narratives of our own lives in healthy ways. Maybe forgetting is not all about pathology, filling holes, those black spaces in your brain. And yet, I think the popular neuroculture presentation of it is something like that. Forgetting is a problem. I want to conclude then with this great quote by Peter Whitehouse. Peter Whitehouse, some of you may know, is a neuroscientist. He's recently written a book called The Myth of Alzheimer's. This is a man who is a major Alzheimer's researcher and neuroscientist. He ends up writing a book called The Myth of Alzheimer's. In other words, he's radicalized the idea of Alzheimer's and started to look at it in different ways. And I like this quote from the book. He says, "We owe it to those who have aging brains not to reduce their humanity to one organ." And I think a lot of the problems that have stemmed from neuroculture and Alzheimer's crisis culture is that we have reduced our humanity to one organ. We've taken upon ourselves to ask of cognitive fitness the answer to all questions about successful life, successful productivity, for being a wholesome human being, for being fit. And perhaps that's not only fair to us, but unfair to all the people around us, especially people with Alzheimer's. The woman in the picture is part of a British campaign that's reversed their images of the sad, selfless, suffering Alzheimer's patient and she has Alzheimer's. And she says, I have dementia, I also have a life. And I think she's wearing jewelry and put on makeup and is a great image to her, a great energy to her. She has dementia and she has a life. They do not cancel each other out. So that's a concluding thought. I want to also end with a couple of recent books, if you're interested, that I've been reading that I think tackle some of the reflections, some of the historical, cultural, and medical ideas I've been talking about. You can make a note of them. I'm not going to describe them all, but these are some books that are trying to make similar points. Margaret Locke from McGill, just by the way, wrote a fantastic book called The Alzheimer's Conundrum that really goes into this into this matter as well, plus a couple of books on neuroculture itself. So I'll stop here. I really want to thank you for your patience, and I welcome Parminder as well. Any questions or thoughts you may have. Thank you.
So I'd like to open it for questions, and if you have a question, please raise your hand and ask the question, and Stephen will answer it.
Oh, you will answer.
Yes, there's a question.
We have to repeat the question.
Yes, if we'll repeat the question if people can't hear back.
At the beginning, it says dementia is a syndrome, and then it lists Alzheimer and other things under it, and then later you call Alzheimer's a disease. If Alzheimer's is part of dementia, why is one a syndrome and the other one a disease?
You called it a syndrome.
Okay.
So the question was, why is Alzheimer's in our talks here both labeled as a syndrome and as a disease?
So in my slide, when I talked about, I actually labeled as a dementia as a syndrome, within which there are several things that show up. And I think one of the reasons that it has been sort of used as a syndrome because it's a combination of different symptoms and issues. And within that, as the whole science of this area has emerged, people have started to label them as more specific diseases. And that's where the Alzheimer's becomes a disease because of the Alzheimer and how people in that area who have researched have started to label these as specific disease. Now, Alzheimer itself is a combination of many different symptoms, and it's in a way, in many ways, a syndrome as well, but it has a label of disease. So that's why it gets used that way in the literature, and that's how I used it as well.
So it's a little bit away from the Alzheimer's, but fibromyalgia is neurological or transmitter syndrome. Is there diseases that come under that? Like if you have fibromyalgia, would that, like dementia is a syndrome of all these. Fibromyalgia is a symptom of all these other kinds of problems.
I know nothing about fibromyalgia, so I can't even comment on that. But if there is someone in the audience who knows about fibromyalgia, Brian or others probably could comment, or Stephen yourself.
I mean, it's an autoimmune deficiency disease, I know.
There's no.
Yeah, I have a somewhat related question. In the, when you're talking about the personhood as being about the mind, it occurs to me that there are other situations in which people lose cognitive function and then subsequently regain it. Anyone who's had a child knows that you're not at your sharpest when you're up all night with them. People who are depressed often have a narrowing of cognition and then come back to being able to do things. Chronic pain and fibromyalgia would be part of that. Certainly chronic pain can lead you to have a very compromised ability to think and to do things. And I think some of the stigma associated with those conditions, particularly the last two, and some of the sense of personhood, it feels like something of the same issue, and those people who've had those experiences may be able to tell you something that you wouldn't hear from somebody
Right.
on a dementia path.
Yes, the question is, how do other experiences that involve cognitive loss or decline, how do they form, in a way, a dialogue with Alzheimer's, especially around the question of personhood and self? I think that's a very important point, that mental powers, consciousness, memory, cognitive health moves in and out of our life course in many ways. Anyone who's had a stroke or knows someone who's had a stroke and seen the rehabilitation that can result after that, I think it's truly amazing what we can do. I just think it's what we attribute to different kinds of heroics around different kinds of problems. For example, some of you may know the work of Pia Cantos at the Toronto Rehab Center in Toronto, who studied a group of women, mostly women who had Alzheimer's disease at the Baycrest. And what she noticed was a kind of ability to communicate with their bodies, that their body language actually got sharper in some ways as they lost other forms of communicative abilities, cognitive abilities. So that one woman, for instance, every time she ate dinner, put on her pearls, because she put on her pearls all her life before she ate dinner. It was a signature of her identity. It was a form of strength. It was a small triumph, in other words. And I think what we need to learn from people with some of the syndromes and problems you mentioned, and people with Alzheimer's, as Parminder mentioned about his father, my grandmother had Alzheimer's, was what we could learn about humanity in general from them, rather than alienating and marginalizing them, is to welcome them as sources of knowledge about ourselves, as we do with children who have autism now. And that the diseases of our time, it's interesting in that light when you think of the biggest diseases of our time, they are not infectious diseases necessarily in industrialized countries, they're not starvation, they are depression, autism, attention deficit disorder, dementia. It's interesting, diseases that can't be cured. We're not sure about the cause. We're frantically trying to look at genetic and other immunological factors, but they need to be managed. They're diseases to be managed and lived with, not diseases to be cured, yet they are diseases. And I think some of the things you mentioned are in that category. They're learning opportunities about self that we, in a way, are missing the boat on. Another question? Yes, sir?
Brain exercise, Zumosity, the jumble puzzle, crossword puzzles, Sudoku. How valuable are they, and are there any studies that show that people that have done those brain exercises versus those who haven't get more Alzheimer's, more dementia?
Good question. The question is, popular brain exercises such as puzzles and Sudoku, do they actually help, and have there been research showing their benefits around memory loss or Alzheimer's? I myself don't know any research about that. There's two sides to that story. One is the use it or lose it motto is a myth, that you could do all the crossword puzzles you want and it won't matter. That's one bit of research. Another bit says that it does help, not so much because of the puzzles, but because you're engaging in some kind of social activity of your own, that you're being active. It doesn't matter if it's Sudoku or doing something else, but you are enlivening your mind and your activity and your sense of social place in a way. You're interacting with environment, etc., and that these are the things that do help. So I don't know. I don't think anybody knows. I think there's been a lot of hoopla made of them, maybe too much. And so people who don't like Sudoku, for instance, are doing Sudoku and hating it. They think, I better bloody well do this or else, no mind in a few years, right?
I was just going to add to that comment that Stephen earlier on mentioned nun study, this idea of that crossword puzzles and things like that help brain came from that because nuns did a lot of crossword puzzles, and maybe that was one of the reasons for their lack of memory loss or not developing dementia. Recently, as part of the launch of our Optimal Aging portal, we have actually gone and looked at the evidence in relation to the games, cognitive games, and whether it has any benefit. Research isn't that strong that it shows that whether it works or doesn't work. And I think there's a fair bit of work to be done in that area. But there's a lot of money that is being put into this to promote something like luminosity and other areas. Even Sony, the big multinationals, are getting into the whole phenomena of promoting games that enhance cognition. There was a question right here and then here.
With the advent of computers and so on, a person of my generation is not so important as what they're trying to say now is with the younger generation that were born always with access to computers and that brains are being rewired, as they say. Will that have any kind of effect, or is there something to this rewiring of the brain that may be something of importance here?
So the question is the computer generation rewiring their brain? And does that distinguish them from perhaps other generations that didn't have access or grow up with computers? I think a lot of our imagery around the brain, restructuring, lighting it up, rewiring, etc., is very metaphorical. I'm not sure any of that as scientifically is actually happening. But what has happened is that the computer has become the metaphor for memory. And it is an interesting metaphor because how could one compete with it? It's always lit up, it's always on, it has huge capacity, it has huge speed. And in a way, we are comparing our minds all the time to the computer. It's almost like a prosthetic brain that all of us have access to, right? I think what is happening, and some studies have shown with the younger generation that are so overexposed to the lightning speed and the endless screens and the endless distraction of screens from this big to bigger and bigger and all the way down again. A connected society where everyone's staring down at a little square object banging into pillars in the hallway. That's supposed to be more connected than ever. It's a bit ironic. But I think they are showing there are cognitive deficits happening in younger generations. And one article I read even predicted that there may be more Alzheimer's in the future for the younger generation than there is currently because of the lack of socialization that goes on with cognitive health. One of the things we have to realize is that healthy memories depend on interaction, on each other. How do you construct a memory? Well, it's usually with somebody else. Oh, I did it last week. No, that was last year. Oh, I thought it was Niagara Falls. No, it wasn't. It was Ohio, right? Yeah. You paid $20 for it. No, it was $300. You got ripped off. Don't you remember?
There's a question here and then back here.
A couple of things, just a quick comment on what you were just saying. I think, ironically, a couple of weeks ago I heard in the popular media, I can't remember what it was, that there was a study that said that actually kids' memories, Gen Y memories are actually reduced because they're taking so many photos that they're focused on the photos and not actually engaging in whether or not that's legitimate, but it would be rather interesting in the context of what we've been talking about. My question actually, Stephen, is about talked about marketing a few times recently, and there's a lot of cheesy stuff going on. But as you've kind of looked at the history of this whole area, have you thought about like what an ethical approach actually is to take products like or a service like Lumosity and to actually speak to it?
Right.
Is there an ethical basis for actually marketing this stuff, or where are we on that?
I think that's an excellent question. The question is there an ethical basis for marketing cognitive and brain products or ways of life itself? And I think that so far we're very much on the line with that, because on the one hand we appreciate it adds to the image of the plasticity of the brain to feed it products. and to feed it kinds of, let's say, neural practices. So if we know, for instance, that a certain food could enhance our memory, and it was marketed as such, is that ethical or not? Well, in a way it is. In another way, it isn't, because it's giving us, I think, a false sense of what cognitive enhancement is all about. This has become a huge issue with memory drugs, as you can imagine. There are drugs that can enhance, apparently, memory, really sharpen memory, kind of, I guess, like hypercaffeine or something. Now, some of these drugs, like the cholinesterase inhibitors, are actually being taken by university students to help them study longer and be sharper on their exams. Other memory drugs are being taken by children, given to them by their parents, to help prepare them for classical music concerts and competitions. Where's the ethics in that? Should we allow that? Should we have classrooms where half the students are taking intellectual or memory enhancers? What about grades? What about tests? So I think it digs deep into that area as well in terms of products. The military is experimenting with everything from drugs to prosthetic hippocampuses. They were trying to develop something during the Iraq War whereby soldiers would not only forget traumatic events, but forget them before they happened.
There's a question here and then back here.
I just wondered if there's any link or discussion about a link between physical activity and Alzheimer's.
Well, Parminder, you could talk about vascular
Well,
dementia.
yeah. I think there is a lot of discussion going on in relation to physical activity and the memory itself for prevention of dementia, but it is still an open scientific question. I don't think evidence has been generated that it shows one way or another. Now, one has to be careful. Basically, physical activity is good for all of us. So we know it is good for cardiovascular health. We also know many other cardiovascular risk factors are also risk factors of vascular dementia that I talked about. So the idea points that physical activity is good for prevention of, let's say, mild cognitive impairment or some of the other forms of dementia, but the science is not there yet to say, yes, it definitely does. There was a question back here and then over there.
The slides that you showed at the start for the advertising across the bottom, and I'm thinking at the very first one, it said something about the neural beverages. And you could have all kinds of different things that they advertise that you're going to get this, you're going to get that, and you're going to get the other thing. The point of that slide, if that was a real slide, it really is interesting because they saw no value in the neural beverages, but if you bought them, we'll give you a free car wash. And I think the free car wash is the thing you're buying.
Yeah, the question is, the slide about the neural beverages selling point was perhaps really the free car wash. I think, yeah, you're probably right. I think you got a drink when you went to the car wash, right? I think that was the whole point. That's. I'll have to look at that again for sure. But I just thought the products were interesting in themselves. You know, neural bliss. It's kind of, you know, that a drink could affect your mind.
There's a question back there and then here.
I think who was next?
It's another question on research. I understand that quantitative research has demonstrated that people with better educations and higher income levels tend to live longer. And I'm wondering if there is any similar quantitative research that indicates that people with better education and better incomes also tend to avoid Alzheimer's longer.
Is that anything in your answer?
Yeah.
You might have to repeat the question.
Question was whether if people who are more educated or have higher incomes, do they tend to have lower incidence of dementia, or do they get less dementia or Alzheimer's disease than people who are not or less educated versus have lower income? We have done some work as part of our group. There was a study a few years ago conducted called Canadian Study in Health and Aging, which was the study of dementia and Alzheimer's disease. And there's a fair bit of literature that does show that if you're more educated, your risk of developing dementia is lower. But the problem with all of this area is that people who are educated, they also fool the tests that we use to detect dementia. So one of the things what we have sort of observed is that the people who actually, we think that they are not getting dementia, they get dementia later, but the severity of their dementia is a lot higher because they have actually have a compensatory mechanisms, which might be a function of their education, that allows them to fool the test that we use to identify dementia in itself. The income in general tends to be an indicator which benefits many health outcomes, not only brain health, and it has to do with good diet, good access to services, and all sorts of those things. So one of the things, and I think this was the comment that Stephen had made in his presentation, this whole idea has gone into what we call the cognitive reserve. People think because you have higher education, which is again the underpinning of cognitive gains, that if you exercise brain either through education or other ways of doing, it sort of allows your brain to sort of regenerate those neurons that allows you to maintain that memory. But how do you measure cognitive reserve is a totally different story. None of us have been able to figure that out yet. There was a question here.
How important are genes to this whole thing? Like if your mother and father had Alzheimer's, are you behind the 8 ball or?
Question is, how important is genetic genes and genetic inheritance to dementia and Alzheimer's? Maybe your research.
Well,
some of that.
There are two types of dementias, or also dementias. One is early onset, that happens in younger population, and the another one is which we call late onset. Early onset has much more link to genetics. There are implications in relation to that. Genetics is one of the major contributors. But in the late onset dementias, especially Alzheimer's disease, it doesn't explain disease more than 10 to 15% of the total disease. It's a lot of other factors. So we still don't know what actually causes Alzheimer's disease. We are still trying to figure it out. Some of the stronger indicators are the cardiovascular risk factors, high cholesterol, stroke, those types of things actually are linked to some of the dementias. But genetics still is a relatively small part of the late onset Alzheimer's dementia. ApoE4, which is one of the genes that people have looked at, and a lot of people who have ApoE4 not necessarily go on to develop dementia either. So there's a lot of work needs to be done in that area still, if the genetic is one of the underpinnings of the disease.
I just want to say, currently there's a study that talk about ethical problems in the Medellin, is it? What's the town in Colombia? Medellin? Medellin, sorry, yes, where they've discovered a village where there's a huge incident rate of Alzheimer's. They have several generations living with Alzheimer's in the same households, actually. And scientists from I think it's University of Arizona, have seized upon this village as a new human laboratory with various kinds of ethical issues arising from that. Set up trailers there. They're testing everybody with every single possible test to try and get it to see if there's some kind of genetic strains that they can identify. But there's a lot of problems with the research as well. They've promised all the inhabitants the benefits of their research in reciprocity for having them be a human laboratory. So I don't know if that's really reciprocity or not.
Anyways, one last question, and then we are going to sort of stop the show because it's already 7:07. So I'll let you ask the last question, and ask it to Stephen, not me.
No.
He's the invited speaker here.
Ask it to whoever you want.
Yeah, I guess I'm just wondering whether when the diagnosis of sort of run-of-the-mill Alzheimer's is made in a culture that's a little more kind, it's a little less uptight about reactive forgetting, is there any observed difference in the trajectory of the deterioration?
Not.
Does worrying about it become a self-fulfilling prophecy?
The question is, does the diagnostic moment in a way affect the trajectory of Alzheimer's or the person's own self-perception. This involves an ethical kind of question too, as to, for instance, when do you tell people? What do you tell people? In response to that, I would like to point out that the diagnostic culture varies. You can have some of the tests Parminder just mentioned. There are tests that can be played with, fooled around with. Sometimes people have a 20-minute test. Sometimes they have an hour test. Sometimes they go to a place like the Mayo Clinic and they have weeks of tests. Sometimes they have tests and other kinds of things like biomarker tests. Sometimes they're called back. Sometimes they're not. We have every kind of variation of scale. The sad thing is if you get a quick test and it's early onset and you take that home and there's no preparation or thought and your family are shocked and you're living with that without even knowing much more, there's no follow-up. We need people to go into the community, to dialogue, to educate, to help. We need various kinds of tests. We need checkups. We need places you can come back and talk to people about. We need a completely different culture than the dismissive one, in a way, we're in. The last point I want to make in relation to that is therapeutics, which is somebody does have severe Alzheimer's or is put in an institution, how should we treat them? Isolation is usually reserved for our worst criminals, but that's often what we do with people who have dementia. Other kinds of projects and other kinds of therapeutic environments are showing something new. First of all, that non-medical approaches from the arts and other areas are very helpful. Secondly, working with environmental areas like the place called the Vicarage by the Sea in Maine does not constrain people. People are allowed to wander. There's a belief that wandering is actually healthy. We all wander, after all. Why shouldn't we continue to wander? They have a beautiful environment. They have bracelets that, are GPS type bracelets to locate them. But they have found the agitation level, the aggression level, the need for antipsychotic medication has gone way, way down in the Vicarage by the Sea. There's also the Legacy Project up in Churchill Stouffville, if any of you want to look that up, that has an enormous arboretum as a care environment. So we're having new experiments on the therapeutic side, I think, that are improving our concept of the humanity of dementia too, that we should all be proud of, we should all work towards, we should all, contribute to if we can.
I think that's a good place to end this evening's session. And I wanted to take opportunity here to thank our funder, Suzanne Labarge, for her generous support of the Labarge Optimal Aging Initiative, and which also provided the funds that also made this event possible. And for many of you in the audience, just to reminder to keep an eye on announcements about other optimal aging public events at McMaster. You can go to the forum website, people who use computers, Facebook, McMaster Daily News, and also the Spectator itself. And mark your calendars for the 2 consecutive days, April 2nd and April 3rd, both at McMaster Innovation Park, which is on the Longwood, from 7 to 8:30 p.m., when we will have 2 public panel discussions of great interest. One on April 2nd about whether and how extended and second careers will become the norm. And the other talk is which actually sort of relates to what Stephen talked about today, on April 3rd, whether celebrities do more good than harm with their medical advice. So I think these are some really interesting topics, and we are also doing a Cafe Scientific on April 6th at McMaster Innovation, February 6th, which is going to be on cardiovascular and vascular aging. So please keep tuned for these wonderful events. And now I wanted to take opportunity to thank Stephen, who actually traveled all the way from Toronto. and we really appreciate you coming here and giving this session. And we have a small gift for you. Thanks very much.
That's very kind. Yes. Very kind indeed. Well, thank you very much.
I get one too? Wow. Yes, thank you. And thanks to all of you for wonderful questions. and engaging conversation. Great.
Thank
Good
you.
night.